Welcome to part 2 of my interview with Dr. Giovanni Mauri. If you missed part 1 of this interview, click the link above to watch that segment. In this bonus segment, Dr. Mauri answers questions from members of the Save Your Thyroid Facebook community. If you'd like to join the community and submit your questions for my next guest, the link is in the description below. So I think now we'll move on to some questions from the community, the Save Your Thyroid community that were submitted in our group. We've already actually covered a few of them in our discussion. The first one was about a patient who noticed a nodule that became sore to the touch, had a biopsy on this nodule and some other nodules, and this nodule was tender to biopsy while the others weren't. There were no calcifications on the nodule or swollen lymph nodes present, and the soreness feels similar to an abscess. What might be the cause of soreness of a thyroid nodule?
Yeah, maybe it's not an abscess, because with abscess you have also fever, red skin, but might be like an hematoma. Sometimes this can be also quite big, being inside the nodule that has been punctured. This can last also 15, 20, or 30 days. It is going to resolve autonomously. The best way to understand that is to do an ultrasound. With ultrasound, it is possible to see inside the nodule what is happening. But I think that might be an hematoma after the biopsy.
Another question is, what causes the rare complication of thyroid nodule rupture after RFA or thermal ablation?
This is a complication that is known from the beginning. Luckily, I never had one, but it is reported in the literature and actually is becoming more a problem. And I do not know if it is a reflection of more people with not a lot of experience starting doing that, with the fear of regrowth, trying to over-treat the nodule. Trying to treat too much in order to have a good volume reduction, and maybe providing some kind of damage on the capsule of the thyroid. That might be one of the explanations. If the heating is too close to the capsule, you can eat the capsule and eventually that can break. The other thing, what a colleague of mine was telling me, is that patients after the treatment too often tends to touch the neck, right, where the ablation occurred. This is something that I always suggest not to do, at least for a couple of weeks, because of course there, even if it is not visible, an ablation occurred, a treatment occurred, and that area, if it is pushed, can break easily. So a suggestion is not to touch the neck at the weeks after and particularly not to push on that area, trying to understand what is happening.
You know, just a comment on that from my own experience. My provider who did my ablations, who is also an interventional radiologist, you may know him, Dr. Owen Park.
Yes, we are good friends.
Okay. He told me that. He said, don't massage your neck, don't touch it, just leave it alone. And he also told me that exposing my neck to the sun would also cause problems because the skin was more sensitive in the time after the ablation. So,
and also you have a very, very, I don't know the English word of your skin. It's very white.
Very fair, yes.
Fair, yeah. Fair, yes. I don't know the proper.
That's perfect. Yeah. Okay. The next question is, why are the probes for thermal ablation so expensive? Do you have any thoughts on that?
Yeah, the technology is quite complicated and it's quite complex. Absolutely. Of course, there can be ways to lower the price. But for example, just think that the needle is cooled. There is a cold fluid going inside and outside the needle in order to keep all the shaft, all the portion that is not inside the nodule at low temperature. Otherwise, we can have skin damage. So in that small needle, there is a lot of engineering, the tip of the needle that is providing the energy and the cooling system of the wall needle. So it's quite complex. On the other hand, with the increase of number, the prices will go down. The production prices are not so high as still they are too often on the market. Let's say, I don't know the price in the United States, but in Europe is still quite affordable. And on this point, we just published a paper on the cost analysis. If you compare it with surgery, it is by far less expensive.
Definitely.
So we have a national healthcare system that reimburses for procedures, and we made an analysis, and they saved a lot of money paying for ablation instead of surgery. I know in the United States it's slightly different, but if a patient thinks how much can cost a thyroid surgery and how much costs a thyroid ablation, I hope also in the United States, ablation is by far less expensive than surgery.
Yes. In fact, I read you had posted about that on, I believe you had posted about that on LinkedIn recently.
Yes, a couple of days ago.
I read about that, and I thought it was interesting because what you noticed was that there was a price savings for the patient in Europe. Well, here in the US, the cost of thyroid surgery is anywhere between $30,000 and $50,000. Now, typically that's covered by insurance. Thyroid ablation, on the other hand, is anywhere between $6,000 and $10,000, and it's typically not covered by insurance. So it's a little bit of a different scenario where the patient has to decide between, do I take the surgery, which is covered by my insurance, and I will have associated costs with that, both financial and health-wise, or do I pay out of pocket for something that's more expensive to me, but maybe less expensive in the long run, both financially and with the health costs. So it's a little bit different, but it's the same concept where the surgery is much, much more expensive, and the patient in the long run will save more money with thermal ablation.
It was a discussion I had with the patient and her insurance, and I was telling her, just try to explain your insurance that they can save a lot of money.
Right.
If you decide for ablation instead of surgery. So I hope also insurances will very soon adopt this technique, because instead of reimbursing for a surgery, they can reimburse for an ablation. So in Italy now, it is widely covered by insurances, and hopefully that will be also the future in the United States.
I agree. I think that once the insurance companies figure out how much money they can save, that they will be begging patients to undergo ablation instead of surgery. So that's a great point. And then the next question is about vascular thyroid nodules. Can you describe what a vascular thyroid nodule is, and do those types of nodules have less successful outcomes with thermal ablation?
Yes, sometimes we see nodules with increased vascularization. Generally, they are those nodules that are also hyperfunctioning. As a general rule, there is a so-called heat sink effect. The blood flow brings out the heating that we are producing. So it's a fluid coming around that area that is taking out the heating. So we need to have extra care of that nodules. Maybe the treatment might be slightly longer and is a little bit more complicated. Generally, we can achieve very good results also in hypervascularized nodules. There are some techniques that is maybe too much technical, where we can start ablating the so-called feeding artery. If we are able to identify the vessel that is producing the vast majority of the vascularization, we can place the needle close to that vessel or even inside, perform the ablation, and at the beginning of treatment, this will stop the blood supply of the nodule and increase the result. But it's more a technical issue but generally speaking, it is possible to treat also hypervascularized nodule with good results.
This next question is a common question, and I really want to emphasize the difference in the term goiter and thyroid nodules. I don't know if goiter is a term used in Europe, but
yes,
patients frequently want to know, can RFA thermal ablation be done on a goiter? I always have to clarify what the term goiter means, but I'll let you do that.
So thank you for the question. Yeah, you are right. It's something that is very frequently asked. So goiter actually mean an increase in the volume of the thyroid that determines a visible expansion in the neck. The technical word is goiter that can be multiple nodules, and it's called multinodular goiter, or goiter that is determined by a single nodule, that is unilocular goiter. So the aim of ablation is to treat the uninodular goiter. It means that when the problem is determined by one single nodule. The ideal situation is a patient with a single nodule. That is not very frequent in the clinical practice. More often, we have patients with a lot of nodules, all very small, but only one or two very big, determining the symptoms. So again, in that case, it is possible to treat also patients with multinodular goiter. On the other hand, we have patients with multiple big nodules, this kind of goiter where the neck is enlarged on both sides and is very large. In that situation, I think still surgery remains the first choice because it's more radical, and with one treatment you achieve the good resolution of symptoms. But I treated a few patients that really didn't want to have surgery, and they were keeping that very big goiter for 10, 15 years. Even if it was determining big discomfort. So in that cases, I remember one patient, I performed 4 ablations, 2 on each side. Of course, she still has some enlargement in the neck, but is by far better. It's always possible to perform ablation. In multinodular goiter is not strongly suggested, but if a patient really do not want to undergo surgery, instead of doing nothing and keeping the situation, we can provide some benefit.
And I would like to add the point that you made about the nodules, the nodular goiter. Sometimes patients ask if thyroid ablation will work on just an enlarged thyroid with no nodules. And I have to always say, well, that's not what the point of ablation is. The ablation is to reduce the size of a nodule, but if you just have an enlarged thyroid with no nodules, ablation is not going to give you that benefit.
Yes, it is very, very infrequent to have a large thyroid without nodules.
And this next question is one we are seeing a lot of patients asking today: can small nodules that are indeterminate be ablated?
Yes, that's a very, very good question, and there's a lot of debate about that. So the short answer is yes. I consider indeterminate nodules as they are cancer for ablation. Okay. So if it is indeterminate, smaller than 1 cm, I consider that as a small cancer and treat the patient as having a cancer. The point is that the patient will never know if that was a cancer or not. Right. After ablation. And I always explain that to patients. If the indeterminate nodule is bigger than 1 cm, I really suggest surgery because they can have the final diagnosis and it is very difficult for me to perform a complete ablation. I mean, if it is 11 millimeter, 12 millimeter, also it can be discussed, but large nodule, I still prefer to send to surgery.
Good point. Okay. So this question is about particularly RFA availability in the UK. Do you have suggestions on how to increase accessibility to thermal ablation in other countries in Europe where it is not very frequently available?
Yes, we are working on that. One of the aim of the last year conference was to involve people from different countries, particularly UK. It was very difficult to find people. I know it is a lot of work. We have to work together on the scientific side, but also patient group asking for that kind of treatment. We have to work together to spread the knowledge about this technique. I'm trying to do that. You also, but it's a long way, I think.
Definitely. I think that these training opportunities that you're providing are vital to getting more physicians on board, particularly in Europe. So I appreciate that you're doing that and all the work that's going into that. We're going to run out of time, so I think we'll just hit one more question. I've got 2 questions I'm thinking about. You tell me which one you want to answer. What nodules are best suited for RFA and which are best for laser? Pros and cons of each procedure? Or does thermal ablation work on parathyroid adenomas? Which one would you like to do?
Yeah, so very quickly, both.
Okay.
Regarding laser or radiofrequency, I
Okay.
think, again, experienced operator can manage both any kind of nodules with the technique that it's using. I treated with laser, very small, very large, with good result, as I'm doing with radiofrequency. So again, that's the same answer that I provided earlier. About treatment after hemithyroidectomy, that was the second question, is correct? Yeah, it is possible. No.
It was actually about parathyroid adenomas.
Oh, parathyroid. Okay.
Yes.
Parathyroid adenomas, I've treated some.
Okay.
Still, I think surgery is provide better results. Let's say, generally speaking, we also just had some paper on that. Let's say half of the patient achieve complete results. The other half tends to recur, particularly for the increase in hormone levels. So, for example, I am generally providing ablation in parathyroid adenoma for older patients with other comorbidities, which are at higher risk for surgery and with shorter life expectancy. Because there, even if I'm just able to treat and the recurrence will occur after 3 or 4 years, I've provided a good result. In a young patient that is perfectly fit for surgery and with a longer life expectancy, providing 2, 3, 4 years with lower level of hormones is not enough. And in that case, I still prefer surgery. I don't know if that answers the question.
Yes. And since you mentioned the hemithyroidectomy, treatment after a hemithyroidectomy, let's go ahead and talk about that really quickly, because that is a question we do have a lot of patients ask is, can I have thermal ablation? I've already had a hemithyroidectomy and I only have one side left. Can I treat any nodules that come up on that side or even thyroid cancer with a thermal ablation?
Yes, generally yes, with the same difficulties of a normal thyroid. I never found more complexity in a patient already treated by surgery. And there are some data also about the need of hormonal replacement, which is not increased by thermal ablation. So if the patient is not taking hormones with half thyroid, after even a thyroid ablation, generally it can continue not to have hormones. So it is possible and with good results.
Excellent. Yes, those patients are particularly motivated to save what they have left of their thyroid. So it's amazing that they have options to avoid a second surgery.
And not to have a second scar and a second intervention in the neck, which is surgically speaking more complex.
Right. Well, Dr. Mauri, this has been very informative. So anyone who wants to reach out to Dr. Mauri, check the description of this video, and there will be links and an email address for Dr. Mauri in the description below. Dr. Mauri, thank you so much for joining me today. It's been an absolute pleasure.
Thank you very much for having me, and congratulations for your job.
Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community, Save Your Thyroid. You can also find me on social media and Substack under the media handle, It's Me, Jen Again. Never forget to educate yourself and be your own advocate and save your thyroid.